I would like to invite our next speaker, Dr. Manish Jain, who would be sharing his ideas on stenting in GI cancers. I invite Dr. Manish Jain, please.
My topic of interaction today is stenting in GI cancer. Stents are basically medical device which can be used to restore the lumen of vessels, duct, and hollow organ like esophagus, colon, and bronchus. In gastrointestinal cancers, stents can be used in esophageal obstruction, biliary obstruction, duodenal obstruction, or colonic obstruction. Stents can be divided into two categories, biliary and antral. Antral again they can be used in esophageal, gastroduodenal, or colonic malignancies. Again, stents can be made of plastic, or can be metallic, or can be made of biodegradable material. Plastic stents again can be simple plastic, or they can be self-expandable plastic stents. Similarly, metallic stent can be uncovered, partially covered, or fully covered. Simple plastic stents are made of Teflon or polyurethane. Self-expandable plastic stents made of polyester skeleton, woven, and completely covered with silicone. Self-expandable metallic stents are made of stainless steel or alloy like alloy and nitinol. These are very tough material used for spacecrafts, has got excellent radial force and excellent capacity to expand at body temperature. Biodegradable stents are made of woven surgical suture material like polydioxanone. So there are different generations of esophageal stents you must have used. Initially, plastic stents, they had very difficulty in placement, high complication rate, and subsequently we have now current generation of stent which are made of basically nickel and titanium, nitinol. They've got a shaft and flare ends. Esophageal stent, the shaft diameter is about 2 centimeter. Flare end, they are basically slightly expanded to prevent migration. Length of stent can be variable depending upon size of tumor. So for patient who has got esophageal malignancy, the indication can be either a patient who has got inoperable cancer leading to dysphagia, whether it is esophageal or extraesophageal, or in patient who has got malignant esophagotracheal fistula. It is important to select a stent which is 4 centimeter larger than size of lesion. For a patient who has got tumor involving G junction, the stent size should be 6 centimeter longer. 4 centimeter of stent should be proximal and 2 centimeter distal, hanging into stomach. For tumor within 2 centimeter of cricopharynx, low flange stent can be used, but as the stent expand, the patient can have one body sensation and respiratory distress and pain. Therefore, it is better to advise radiotherapy or chemotherapy to these patients. There are certain steps and tips for successful stent placement. You must confirm indication, go for histopathological confirmation, because once you deploy a stent, it's very tough to take biopsy. Obtain a good roadmap of lesion by performing a X-ray contrast study if possible to assess the length, tightness, and angulation of stricture. Select appropriate scope. Suture dilatation is required. If pediatric scope is not negotiable across the stent, proximal and distal end of stents and stricture need to be marked appropriately for proper stent placement, and carefully read about stent and delivery device details beforehand. This slide shows different steps in deployment of placement of esophageal stent. This is how stent looks like when fully deployed endoscopically. All procedures, they have got their own complications. Similarly, stent has got its own complication. There are early complications within 4 weeks or delayed complication after 4 weeks. Early complications are chest pain, fever, bleeding, reflux, and global sensation. Some patient can have perforation and stent migration. Late complications are tumor ingrowth, stent migration, development of esophageal fistula, especially at upper and lower end of stent, and there is recurrence of stricture, which is always a feared complication. As we discussed today morning, in patients who present to us with colonic malignancy in obstruction, all patients who have got metastatic colonic cancer, stents can be placed as palliative care if they come to us with obstruction. And a patient who have got operable malignancy, especially left-sided, they present to us with colonic obstruction, you can place stent because there was a wonderful study published in World Journal of Surgery in 1999, which has shown that it allows excellent decompression of colon. Bowel preparation can be achieved prior to surgery, and colonoscopy can be done to look for a synchronous lesion, and therefore, rather than going for a two-stage surgical procedure, we can convert into a single-stage or even laparoscopic surgical procedures. In patients who have got lower rectal cancers, stents are poorly tolerated, so better to avoid. This is how endoscopically the stent placement looks like. Oh, sorry. This is again basically a patient who presented to us with acute colonic obstruction secondary to operable malignancy. The stent was placed, and within 15 days the surgery was performed. This is resected specimen showing stent as well as tumor. It is important to remember that colonic malignancy, if you place stent, the complication rate are higher than that of esophageal malignancy. Complication rates are 7 to 17%, and technical failure are more high if the stent size is, if the stricture is longer than 4 centimeter. Major adverse event which can happen is colonic perforation. So these patients are already very sick and morbid, so this can be a fatal event in these patients. In patient who has got gastroduodenal malignancy, there can be different mode of palliation. In advanced malignancy, it can be duodenal stenting, it can be surgical gastrojejunostomy, or it can be endoscopic ultrasound guided gastroenterostomy. This is putting a duodenal stent is the simplest procedure which you can perform. You have to simply put a stent. Every gastroenterologist is expert in putting duodenal stent. Simple procedure, hardly any complication. So all patients who have got expected survival of approximately 6 months, you can go for simple duodenal stenting. There are tips for successful stent placement, and overall technical success of gastroduodenal stent placement is about 95%. And there are different studies in literature. There are plenty of studies which have compared gastrojejunostomy and duodenal stent placement. Just give me 2 minutes. This is upcoming modality for palliation in patients who have got gastroduodenal obstruction. You can place endoscopic ultrasound guided stent, and there are basically this study which was recently published in a multicentric trial. It has shown excellent potential of this modality for palliation. In patients who have got malignant biliary obstruction because of variety of reasons, you can place stent, but important point I want to highlight here before placing any stent in patients who have got biliary malignancy is surgery with R0 resection is only hope for cure. So don't rush for ERCP in stenting in these patients. After a sonography, cross-sectional imaging is first line workup. So high quality, preferably triple phase CT with or without MRI, or if the patient can't afford, patient has got a hilar lesion, only MRI should be next imaging after USG prior to EUS or ERCP. And try to establish histopathological diagnosis prior to ERCP or drainage by doing some percutaneous procedure or by doing endoscopy and biopsy. In patients who have got biliary obstruction, which stent to choose, plastic or metallic? Obviously, the metallic is first choice because of better drainage, less re-intervention. But plastic stents can be used in common bile duct and lesion up to common hepatic duct when the cost is major consideration and histopathological diagnosis is uncertain. This is Bismuth classification which we use for basically finding operability and the level of obstruction in patient with cholangiocarcinoma, but same can be applied to find out site of lesion or depending upon or selecting type of stent in patient who have got CAGB. In patient who have got cholangiocarcinoma, tissue is the issue. In majority of patients who have got malignant obstructive jaundice, tissue is the issue. Cytology and biopsy alone has got sensitivity and specificity of about 45 to 48%, and combination you can pick up diagnosis in about 60%. 20% of biliary strictures are indeterminate, and hence detailed workup like USFNA in case if there is distal lesion or fish or cholangioscopy might be needed. About 15 to 20% of patients who are operated for suspected malignant stricture turn out to be benign, as covered stent once deployed cannot be removed without surgery. Prior tissue diagnosis is of paramount importance. This slide we have already discussed in morning, stent in operable biliary malignancy. So I summarize by saying that stents have certainly revolutionized the endoscopic management of malignant GI obstruction. Careful assessment of indications, contraindications, stent and delivery device details prior to every procedure is key to successful stent placement, and I thank you for kind and patient listening. Thanks a lot.